I'm David Bradford. I'm the George D. Busby Chair of Public Policy at the University of Georgia.
My name is Ashley Bradford. I'm a master's student here at the University of Georgia in the Public Administration and Policy Department.
We're here this morning to talk about some of the work that Ashley and I have done together, looking at the intersection between medical cannabis laws in the United States and the growing opioid epidemic. As many of you probably know, opioids are prescription drugs and illicit drugs like heroin that are commonly abused in the United States. And there has been a rapidly increasing wave of deaths nationwide, but certainly concentrated in Appalachian region stretching from Mississippi, Alabama, Georgia, up through northern New England. To the point, as of the last year, in 2016, more than 33,000 people died in that year from opioid overdoses, both heroin type drugs and prescription drugs. And that's equivalent to about 2 747 airliners crashing every week. And so as this wave is accelerating, one of the things that policymakers are trying to do is to understand what tools can be brought to bear to help constrain the growth of the abuse and misuse and deaths associated with opiates. And one of the areas that Ashley and I have studied is the degree to which medical cannabis laws can be a tool in the arsenal to try to combat opioid addiction. So actually, because of some interest that Ashley had, we did a study that was pretty well received this past summer looking at medical marijuana and Medicare spending. Actually, I don't know if you want to tell them a bit about that.
Well, a lot of research has been done in the area of spillover effects and negative externalities that are associated with medical marijuana laws. So people are studying how it affects health outcomes and educational outcomes, but no one had really been looking at whether or not it's being used clinically to be a replacement for medicine. And so we were really the first people to look at this issue and to study whether people were substituting away from pharmaceutical medication and towards medical marijuana, and we found that they were treating marijuana as if it was a new FDA-approved medication that just came onto the market. They were substituting away from these prescription medications, and instead they were moving towards using medical cannabis as their medication.
Yeah, and one of the big findings from that is not only did, as Ashley said, did we look at a broad spectrum of medications, but we looked at pain medications in particular. And when we examined this in Medicare Part D, which is the prescription insurance component of Medicare, which is insurance for older Americans, we found that the biggest component of the change was in pain medications. And so there we saw something like, was it 1,900 fewer doses per doctor per year written when states turned on medical cannabis laws. And in 2013, that would have translated, if all the states had turned it on, overall it would have been about $500 million less in spending. We've since extended that study, and we have another year of data, and we again looked more particularly at pain with 2014 and examined, since we had more data, whether dispensaries or home cultivation were different pathways. And as you would expect, when dispensaries were the pathway of supply for medical cannabis in those states, there were even bigger reductions in pain medication use. Something like 2,400, I think, daily doses per year. So if you turned on dispensaries in all the states in 2014, it would have been nearly $1 billion across all disease categories. But most critically, we would have seen a significant reduction in pain medication use, much of that being opioids. And we've got a similar study coming out about Medicaid.
Mm-hmm. That's about to come out, and we found even bigger findings there. So we found that pain prescriptions fell by 11%. 11%.
Yeah.
And I think our counterfactual cost estimate was $500 million.
As it stood, yeah. If every state turned it on again, over $1 billion. So
there's cost savings, and there's people's lives are being saved.
Right. We've done additional work that's just entering the review process right now, that we have presented at a few international conferences, that looked at the impact of medical marijuana laws on opiate deaths. And what we found there was that when states turned on dispensaries, the opiate-related deaths fall. So we looked at all counties in the United States from 2010 to 2014, I think it was. And when states turn on dispensary-based MMLs, we see a significant reduction in opiate-related deaths. So we do think that medical cannabis is a tool that policymakers could use to help divert people away, it seems, from the initial use of opiates that might come through dental procedures or minor surgeries or acute back pain, things of that sort. People prescribed opiates. Opiates are highly addictive. Many people can become addicted and then move on to the path of misuse and abuse and ultimately death. And if they can be diverted, and there's a lot of clinical evidence and growing evidence that suggests that cannabis is one effective tool for treating chronic pain. If you divert people away from opiates, then they never get started on that path that would lead them to death. So we're pretty excited about the research and look forward to more of that. Ashley, in fact, is just starting a project right now, trying to understand how it is that the process by which states approve these laws. So that's exciting.
Mm-hmm.
When states turn on medical cannabis, we see that pain medication use falls. When we got additional data beyond what was possible with our study from this past summer, we were able, because of the additional years, to actually examine dispensaries versus home cultivation. And what we found was that the biggest pain reduction in prescription pain use comes from dispensaries opening. That when you compare dispensary-based systems to home cultivation-based systems for medical cannabis, you do get a reduction in pain use for pain medication use for home cultivation, but it's a third the size of the reduction you get when a dispensary is turned on. And that just makes sense. I mean, if you think about a patient going to the doctor with some sort of pain, and the doctor could say to the patient, well, in a home cultivation state, here's a prescription for an opiate, or you could try medical cannabis, but you're going to have to go home and grow it yourself. That'll take you 3 months. You'll need a climate and light controlled room in your house, etc. That's not a very viable option for somebody with immediate pain problems. But if the physician can say, oh, here's a prescription for an opiate, go down to the pharmacy and fill it, or here is a recommendation that will allow you to go down the street right next door to the dispensary and get medical cannabis, you can try that, then it's much easier for people to substitute to cannabis. And in fact, what we're finding is that, as you would expect, that's where the big effects are.
All right, so just as marijuana is a substitute for the opiates and the pharmaceutical medication, dispensaries are substitution for pharmacies.
We looked at it in 2 ways. One is just turning on any kind of medical marijuana law. And we saw significant reductions there. But then we got more data and we could ask, okay, what kind of medical marijuana law gets turned on? Is it home cultivation only, or is it home cultivation plus a dispensary? I don't know that there are some states that just do dispensaries without home cultivation, right? Some of the recent ones, right? So is there a dispensary option? And most importantly, not just has the state approved a dispensary, because many states, Delaware, as I recall, approves, or is it Maryland? Maryland approved a dispensary system, and then the first dispensary didn't open for 3 years. I mean, so there can be a long delay. So most importantly, we ask, is a dispensary open and active? And then when the answer is yes, then we saw bigger effects there than if home cultivation were the only mechanism. I guess one thing that I would add is people are thinking about the future of policymaking with regard to opiates. And as we're entering into a phase in sort of a disruption, if you will, in national health policy, where the status of the Affordable Care Act is still a little bit uncertain, the degree to which mental health services and substance abuse services are going to be subsidized is a little uncertain. We as researchers, we as policymakers, we as citizens who vote need to bear in mind that the opiate crisis is not only a serious problem, but it's a growing problem. There's a type of opiate, a synthetic opiate called fentanyl, that is extraordinarily effective for pain management. It's developed for patients with breakthrough pain and cancer. It's extremely powerful. It's 100 times more powerful than morphine, about 50 times more powerful than heroin. It's deadly to take if there are no opiates in your system. It was never intended to be used for people who weren't very seriously ill, already having difficulty managing their pain with opiates, and this is just an add-on therapy. It has unfortunately become a drug of abuse. 1 million doses of fentanyl will fit in the size of a shoebox of raw fentanyl. And so the transportation capabilities for drug cartels is just enormous for this. The ability to move product from the Mexican border through New England and into Canada. Canada's really suffering from fentanyl right now, is extremely high. Unfortunately, illegal marketers have gotten their hands either on a lot of active ingredient or they've learned to synthesize it themselves. And we're seeing the beginnings of a wave of fentanyl abuse. Fentanyl is a drug, unlike heroin, which may stay in your system for a day, and heroin abusers may not dose themselves but once a day. Fentanyl is metabolized quickly. Abusers typically dose themselves 4 to 5 times a day. Very, very small margins of error before respiration is suppressed. So I think that one thing that people are, as we're thinking about policy and the opiate epidemic, is that it may be getting much worse before it gets better. And so this really is an all hands on deck situation. And I think it would be foolish of policymakers to neglect avenues of diverting people from opiates. Maybe the DEA and the Attorney General and some state policymakers are suspicious of marijuana, but they should be terrified of fentanyl. And as a consequence, we need to take advantage of whatever tools we have.